Thank you, Bob. I feel very honored to get the award. There are not that many awards in psychiatry. It's very meaningful to me, and particularly to be in the company of the previous awardees. Because I evaluate drugs, I don't accept any funding from the drug companies at all. Chlorpromazine, the first antipsychotic and the first big drug in psychiatry, was discovered when I entered college. And by the time I got to medical school and residency, psychiatry was entirely psychoanalytic and remained so, for 20, 30 years after that in academia. The drugs were used in state hospitals. But if you mentioned you used a drug in training, you'd have your countertransference analyzed as to why you doubted your ability as a psychotherapist. They had to use a medication. But I became interested in how to use drugs, the implications of their biochemistry for the causes of mental illness. And Don Klein and I wrote really the first scholarly textbook of psychiatry, where we reviewed the evidence as more of a narrative review of a box score showing drugs were shown to be efficacy or studies which didn't. But it suddenly popped into my head a better way to analyze the literature quantitatively. And so I did a review of the drugs to treat, to prevent relapse in mania, in depression, and in schizophrenia. And at that time, these drugs were seen as tranquilizers, as sedatives. And many people thought that once the patient recovered and went home, they didn't need medication anymore. And right from the very beginning, people were observing relapses. But so what I did was I tabulated in each individual study the number of patients who relapsed and the number who did not in these long-term studies. And I had read a paper in college in Biometrica showing how to combine the data. And so I used that statistical method. And this was the first meta-analysis in psychiatry, the second in medicine. You can calculate the combined probability and also measure the consistency. For antipsychotics at the time, there were 26 studies, 3,000 patients. 65% relapsed on placebo, 32 drugs, with a 35% difference. Now we think, in statistics, 0.01 level is something that's significant. That's 1 with a 0 in front of it. This is 1 with 87 zeros. With lithium, there are around 10 studies, equally significant. With the antidepressants, at this time, there were only 5 studies, but it was still massively significant. The second thing I want to show a slide to explain the mathematics. And I took as an example college basketball, where you have a tournament and you have 30 teams competing, half of them lose. And then you go on to the next round and the next round. And in a couple rounds, there's 8 left and 4 lose, down to the last round where one loses and 1 wins. This is illustrative of the time course of relapse with schizophrenia or with mania and depression. The number who relapse goes down rapidly in the first, but the rate of relapse stays the same. And you can't assume that because a patient doesn't relapse, they won't relapse later. There are some exceptions out of people who will never have a relapse, but almost everybody relapses without maintenance medication. And if you plot it with this straight line indicating a constant rate of relapse, it fits very well to the data. A lot relapse on placebo, some with drug. Now, I'm going to switch topics now and compare the efficacy of drugs in internal medicine to the efficacy of drugs in psychiatry. People look down on psychiatry, but the outcomes are very different, but you can calculate the patients who have a good response and the patients who don't. And I showed you before, there's about a 50% improvement, like from 60% relapse to 30 or something like that. Now here, aspirin to prevent heart attack and stroke in people who've had a heart attack and stroke. The numbers is 6.7% versus 8.2%. From primary prevention of giving baby aspirin to healthy people, it's just a fraction of a percent for a repeat heart attack and stroke, or the initial heart attack and stroke, and you can't really show it with, in primary prevention with death. My second example is long-term follow-up of chemotherapy for breast cancer. 15 years of the younger women, 42% die on drug, 42% die on placebo, 32 on drug. For the older patients, it's a 3% difference. Now, when penicillin was discovered, sulfa was the common drug for pneumococcal pneumonia. 12% died. Penicillin reduced it to 6%. When streptomycin was discovered, about 2/3 of the patients had a poor outcome. It could be reduced to 1/3 with streptomycin. And so we did an examination of 48 drugs used in general medicine, compared it to 9 in psychiatry. And I have the psychiatry in the solid dots and the medicine in the open dots. And I think our psychiatric drugs fall in the general range of drugs used in internal medicine. It's rare that the drugs used in internal medicine are curative. Now, the second topic, just for one slide, is I was involved early on in working with plasma levels of antipsychotics and correlating it with side effects. And we found here that an intramuscular injection of chlorpromazine produces a high plasma level. The same dose orally produces a very low plasma level. And when I gave this talk in the 60s, a very distinguished pharmacologist got up and said, from the basic structure of chlorpromazine, we know that it should completely penetrate the brain. And either you had to throw out all the physical and chemistry, or you had to throw out Dr. Davis's data. But in the next few years, the pharmacokinetics was worked out, And so now the drug companies investigate this long before a drug reaches the market. And after the meta-analysis, there were a few meta-analysis in medicine up till the 90s, and then it took off in the 90s because the British group became very interested. And now there are 20,000 meta-analysis. And if I tried to get a grant for the plasma level studies, it's very likely people would have said it was impossible. And for the meta-analysis, it hadn't been done before. You couldn't get a grant. And that's why funding for innovative work is so essential. In this case, I picked that because you know the right answer. Now the drug companies are required by the FDA to do maintenance studies to get a drug approved. So now a lot of this, nobody pays attention to psychiatry, but a lot of this it came about, was these things in many fields, but some of the earliest was done in psychiatry. Now, for my last topic, I'm going to diverge a little bit, but I have colleagues interested in nutrition, and they wanted to analyze studies using meta-analysis. And 60 years ago, the diet-heart hypothesis was formulated, and the advice to people not to prevent heart attacks is don't eat fatty meats. But if you tell people not to eat fatty meats, you need to tell them what they could eat. So you can say don't eat fatty meats, but eat a balanced diet, including fish. Or you can say don't eat fatty meats, and we'll provide for the study omega-6 corn oil-rich salad dressings, margarines, and cooking oils. So I split this study up into two groups. The group told to eat a balanced diet had a decrease in heart attack and stroke. These were randomly assigned control studies. But the group that were assigned to eat a substitute with vegetable oils provided by the study didn't have any benefit. But the really interesting thing was that two of the studies were never published in any detail. Virtually nothing was published on them. And since these were done 60 years ago, but we tracked down the last surviving investigator of one, who was a research assistant, assistant dietitian on the study. And we found the raw data, or he had the raw data. And here is the vegetable oil intervention, the so-called heart-healthy intervention, increasing the death from heart attack and stroke by 70%. It would have been contrary to the prevailing wisdom. Unfortunately, the other study, there was no surviving investigator. And principal investigator was survived by his wife, who let us search the basement. And we found much of the original data. And the experimental diet did lower cholesterol quite substantially, but more people died and on the experimental diet, and the more they lowered cholesterol, the higher percentage who died. And of those who died in the autopsies, there was almost statistically significant more atherosclerosis in the experimental diet, the heart-healthy diet, and more evidence on postmortem on MIs. And Now that was, you couldn't have, I mean, the prevailing opinion was that heart-healthy diets with high vegetable oils was proven by epidemiologic evidence. And you couldn't have get a grant to do anything different. And these people were chicken to publish their results because they were contrary to the general opinion. And that would be another example of the importance of private funding, which can take a chance on a good idea. And when I was at NIH, I worked with a Nobel Prize winner, Julie Axelrod. He hadn't won the Nobel Prize at that time. But after he won it, I asked Julie for a secret. And he said, perform many pilot experiments. And he said also he knows when to get out from a study. Some people persist and persist. And he said, work on an important problem. He said, you know, John, it's as much work to work on an important problem as to work on a minor problem. And I think it's very relevant to this organization to perform many pilot experiments. And in one of the nutrition studies that I did, a reporter from the Economist heard it. And so the Economist wrote a story on it and put a cover on it. So this was my view of the ascent of man and diet. Yeah, thank you for your attention.
Thank you, John. Questions? Let me just start. So you've been doing meta-analyses for many, many years. The science has moved forward in terms of how you do them, and of course the computing power and all that. And the number of studies that you can put in have just exploded. How much better is the information that we're getting from these kind of studies now as compared with in the past?
I don't think it's all that much better. Mm-hmm. It's getting now highly mathematical.
Yeah.
And you don't know, if reality fits with the mathematics.
So you feel that we haven't really moved forward in terms of the knowledge?
I think we've moved forward some, and if you want to analyze a lot of studies and combine the data, that it's a lot more powerful. But sometimes, by the time you have a lot of studies, the issue is already published. And the other thing is meta-analysis. You have a couple, investigators often look hard for their pet hypothesis. And if you have a study where they look a little bit too hard, that difference is carried through in the meta-analysis. So, but it's a complicated. I'm not 100. I think it's a useful technique, but maybe more abused or taken too seriously now than really it need be.
Okay. Could we get the house lights up a little bit? So, yeah, great. Are there questions?
Oh, I can show.
Okay.
I have another slide. Just hold on. Now, Bob was referring to the meta-analysis that we'll do massive numbers of studies. This is one of mine with 212 studies, 43,000 patients. And the mathematics is highly complicated. Mm-hmm. And you can ask, why do we switch to the new mathematics? Here's why.
That's good, yes. Does she work for the NIMH? Yes, sir.
Dr. Davis, thank you very much for your and perhaps talk about one other thing. I 41 years and then in practice. I'm sorry, is that better? Yeah. Okay, I've had a 41-year career, both in training and in practice in psychiatry. And I've watched much of the evolution that you've described, because in the early years, there was tremendous reticence to prescribe medication to help patients. And then I think things started to improve, although there was a great deal of resistance on the part of psychiatrists to use more than one medication and at a time if a patient had symptoms of one or two disorders simultaneously. So you've shown very clearly the efficacy of both acute treatment and maintenance for the treatment and then later prevention of relapse. One of the things that I often encounter in practice is a resistance by patients to continue adherence to a medication regimen. So I think one of the things that can be taken away from your talk is the need for education of patients in to support the efficacy of active and appropriate treatment, and to impart hope for those people that they can get better and stay better. So I applaud your early work, and I enjoyed your presentation very much.
Thank you.
Thank you. Yes, ma'am? Yep. Here's a mic. We want to be able to hear you.
Can you hear me?
Yeah.
When patients don't adhere to the maintenance therapy, the medication therapy, oftentimes it's because of the side effects. In terms of all of your studies or any studies coming up, is there anything that can show whether it's in how it's administered, whether it's orally or you were indicating through shots? Is there something that can improve or take away the side effects that patients are objecting to, such as feeling drowsy, not feeling a lot of energy, that can help them to stay within their medication program?
I couldn't hear.
Well, the question is about how the side effects really affect patient adherence and choice, and what your thoughts are about that, and whether the mode that the medication is given, I guess orally or IV or something like that, can affect the side effects.
Yeah, both.
Yeah.
And I think a lot of the art of psychopharmacology is managing side effects. And there's not much research on side effects. So it's really an under-researched area.
And I agree very much with Dr. Davis that I treat a lot of patients with bipolar disorder, and they're on medications for a long time, and pretty much none of the medications are fun to take. So really management of the side effects and being attentive to that and see what you can do to be helpful makes all the difference in the world of whether people are willing to stay on the meds or not, and then stay out of episodes. So that's a very, very important question. Any other issues? Yes, ma'am. Hmm?
And I want to mention two side effects which I found to be particularly dangerous. One is sleep apnea. And I've seen doctors for 30 years now. No doctor has ever mentioned the possibility of sleep apnea. Yet when I went to a sleep specialist, first question was, have you suffered from mental illness? Second side
John, do you want to?
I didn't hear.
Oh, there are three side effects that you asked about. One is sleep apnea, the other is addiction to benzos, and the third is weight gain. And with bipolar treatment, and whether you want to comment on those?
I think there's a choice of antipsychotics, and I think it's important that patients switch in somebody who's gaining a lot of weight to one that produces minimal weight gain.
Right.
And the patients gain the weight sort of in the first 6 weeks or 8 weeks, and you can identify patients early and switch early.
Right. I mean, weight gain is a big problem with, not to mince words there, with almost all the treatments we have for bipolar disorder and management of that. There are a number of things you can do, but it's a problem. And certainly sleep problems, including sleep apnea, are very, very common, frequent in patients with bipolar. And benzodiazepines, that's a whole subject, a big subject, and there are lots of good reasons to use them, and there are lots of problems when you do use them. So, but suffice it to say, we'll just leave it at that.